Good afternoon, everyone, and welcome to our Wounds webinar, Healing Together, Wound Care for Aged Care Nurses. My name is Deb Peluso. I'm the Project Lead, GP Matching Aged Care at Western Victoria PHN, and I'm your facilitator for this afternoon. Before we kick off, I'd like to acknowledge the Wathaurong land that I am living and working on and pay my respects to the elders, both past and present. We at Western Victoria PHN support self-determination for First Nations peoples and organisations. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. And for those that don't know, PHN stands for Primary Care Network. We will put the link to access our recorded webinar events into the chat. Please see our upcoming events on the screen now. You can register for our events on our website. We will put this link into the chat for you also. Thanks, Jade. Our workforce development team is busy planning our 2026 education and training calendar. There's also a link in the chat where you can submit your education and training requests for inclusion. We would love to hear what topics you're most interested in learning about. You may have seen that we've recently launched our new Learner Network monthly newsletter. It's the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code now on the screen. Editions are released on the first Tuesday of each month. And a reminder about Health Pathways, a free online resource providing localised clinical and referral information for health practitioners. The Wounds Pathways have recently been updated, so now is a great time to take another look. A certificate of attendance will be emailed to participants. Please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, please rename yourself or type your first and last name in the chat box now, and this will ensure we can issue you with a certificate of attendance. This event is being recorded. Please keep yourself on mute for today's session. Due to the large number of registrants, we will take questions through the chat box. Please feel free to type questions in the chat box at any time and they'll be addressed during the designated Q&A time at the end of the formal presentation. Your feedback is important to us, so please take a moment to complete the event survey after the webinar. A link will be shared in the chat and we'll display this QR code again at the end of the session. Our presenter for this afternoon is Dr. Geoff Sussman, OAM, Ph.D. Dr. Sussman is an Adjunct Professor of Wound Care in the Faculty of Medicine, Nursing and Health Science at Monash University. He's also the past President of the Asia Pacific Association for Diabetic Limb Problems and a clinical lecturer in medical education at the University of Melbourne. I'll now hand over to Dr. Sussman.
Well, good afternoon, and it's a pleasure to be with you once again. Today we're going to talk about wounds in particular with aged people, and unfortunately the facts are this, that Australians are living longer, and when you look at the projected lifespan, the birth expectancy projected to be 95.1 years for men and 96.6 for women, compared to 91.5 and 93.6 today. So there are going to be 40,000 people over 100. And within a relative short time, a quarter of the Australian population are going to be over 65. So it's important we understand ageing and we understand the implications it's going to have on your practices. So what happens to your body as you get older? Well, first of all, it affects your cardiovascular system. You get decreased vascular elasticity. The blood flow goes down, but the peripheral resistance goes up. It affects your gut. You don't have much protein synthesis. You lose your teeth, the saliva, the taste sensation. The gut doesn't work as well. Genitourinary, you have problems with bladder strength, capacity, GFR. Your lungs, the elasticity of the lungs goes down. Vital capacity goes down. Musculoskeletal, you're not as strong as you used to be. You get erosion and ossification of joints. You get osteoarthritis of the knees, the hips. All of this is an issue. The muscles become thinner. The nervous system. I haven't got hearing aids. I haven't got glasses. I'm doing pretty well. But for many, vision and hearing becomes a problem. And your immune system changes very significantly as you age. But what about the skin? What happens? Well, you lose about 80% of the original thickness of the dermis, which is among the thickest parts of the skin. You have 40% less collagen, you produce less sebum and sweat, and the epidermal layers separate easily. That's why you get skin tears, which I'm going to talk about in some detail later on. The elastin fibers, however, decrease but become thicker, so it makes the skin sick. You lose the Langerhans cells. Now, the Langerhans cells in your skin are part of your immune system. They prevent skin infection and skin allergy. Your blood vessels diminish and become fragile. You no longer produce vitamin D, and I cannot overemphasize this. Everybody should be taking vitamin D, because vitamin D is not a vitamin. It's a hormone. And the evidence grows every year that low vitamin D plays an important factor in multiple sclerosis. In pregnant women who are low in vitamin D, when the baby comes to term, the baby is more likely to have eczema, asthma, autism. This we know. So very important. And when you look at the skin of a young person to the old person, you can see the different pictures there. And look at the actual structure of the skin changes. And also the little reti pegs, these little clips that hold the two levels of the skin together, disappear. So therefore, the skin deteriorates very rapidly. So less Langerhans cells, less melanocytes, less Meckel cells, less elastin, less collagen, less sebaceous, less sweat. The pH acyl mantle is impacted. Again, the blood supply is impacted. The fat layers change. So it's not good. And the skin becomes even more important as we age, because you've got this program aging of the skin, and the skin becomes fragile. And it's important we look after our skin. And I'm going to be talking of some detail of how we do this. The fibroblast, such an important cell for producing elastin, collagen, decrease in number. And you notice it mostly on the face and the neck and the upper arms, where the skin sags. It's no longer strong, and the tensile strength goes. You get these yellow papules as well that appear, particularly in women. Not so much in men, which is interesting. The sweat glands become smaller. You get xerosis, or very dry skin, particularly around the legs, the elbows, the forearms, and the hands, particularly in winter. And the skins tend to feel rough and scaly, and often it's due to poor hydration. I can't overemphasize that as part of a good nutrition, you have to drink plenty of fluid, and that's very, very important. Again, the vasculature changes, and that has a major impact, because remember, the blood supply controls thermoregulation. That's what reacts to both hot and cold. And this is very much an impact. That's why older people are at far greater risk of heat stroke because of this. The cell-mediated immunity, you lose the Langerhans cells, and therefore older people tend to get more skin infections and more skin allergies. And again, I can't overemphasize the vitamin D, because normally that's produced in the skin, but that disappears. As an assessment tool, it's been around for a long time, but the time principles are probably one of the simplest and easiest one to use. Again, tissue, inflammation, infection, moisture, edge. You want healthy tissue, red granulating, peak ethylization. What you don't want is slough or necrotic tissue. All wounds are inflamed, particularly chronic wounds. That's a factor of the release of cytokines, tumor necrosis factor alpha, the interleukins. And this is a normal thing in a chronic wound, but then that's not good, because that delays healing. And if you have a look at this particular wound here, This is a young man, actually, not an older patient, a young man who's had these wounds for 8 years. I was asked to see him, and I took myself to Box Hill Hospital where he was an inpatient, and he was getting antibiotics. He's had antibiotics for 8 years because they said it's infected. I said, stop the antibiotics. It's not infected at all. They said, but look at the cellulitis. I said, there is no cellulitis there. They said, what? I said, what colour is the peri skin? Is it red? No, it's purple. This is the violaceous halo of vasculitis. So for 8 years, they were treating the wrong thing, which is not good. But if something is truly infected, we need to find out what the bug is and treat it specifically with the antibiotics that are susceptible for this particular bug. So that's a diabetic in the picture. You can see the probe has gone right through the foot. So that's going to have osteomyelitis. Because if you can probe the bone, 85% chance of osteomyelitis. And I'll talk in some detail about infection. Moisture. We know from Winter's early work that for a wound to heal, it needs to be moist. It doesn't need to be wet. If you wet a wound, it becomes macerated. That you don't want. But if it's too dry, you just get an eschar there, which again you don't want. So it's getting the balance right. Enough moisture to let the cells replicate, but not too much to macerate, not too little to dehydrate. And the edge. The edge needs to be healthy because wounds get smaller by contraction at the edges. But if the edge is unhealthy, that impacts very much on the ability to heal. Now, many people heal very easily, but many don't. And there are factors both within our bodies and in our environment. Your health status. You need good circulation, both venous and arterial. Your immune function. If you're immunosuppressed, you've got a problem. I've talked a little about age factors already. Body build. If you are obese, you have a problem healing. Why? Fat doesn't contain blood supply, and that's an issue. If you are malnourished and underfed, that's a problem. If you've got comorbidities like diabetes, rheumatoid arthritis, lung disease, all of these will impact on healing and nutrition, which I'll talk about in some detail a bit more. And then extrinsically, mechanical stress, foreign material in a wound. If you're cleaning a wound, don't use cold water or cold saline. Warm it up to body temperature. Dry is bad, wet is bad. Infection, which I'll talk about, and then chemical stress, and remember smoking and medication. So, in my clinic at the Austin, I have a dietitian, and every new patient sees the dietitian because a balanced diet, especially protein, is going to have a huge effect on the ability to heal. And with some of our wounds, like our pressure injuries, we give them vitamin C. Why? Vitamin C is used in the production of collagen. You take some amino acids, which you convert to proline. Proline becomes hydroxyproline and becomes collagen. So that can be very useful as well. Now, drugs. Drugs are an important part of the way we treat diseases. However, there are a number of drugs that impact on healing, particularly steroids, whether oral or topical. Non-steroidal anti-inflammatories, I really don't like them as a drug group because they have a very potent impact on wound healing. But unfortunately, they're used, in my opinion, used too often. Why? When codeine, which was our up-build from ordinary paracetamol, was restricted and became prescription only, people looked to taking Nurofen or Voltaren or similar for their pain. But these drugs have some nasty side effects, both cardiovascularly, kidney effects are not very good. And it's very, very important. Before you use an NSAID on any of your patients, you must make sure they're not taking an ACE inhibitor, an ARB, and a diuretic. Because if they take those two drugs, they must never use NSAIDs. Why? It will have what we call the triple whammy effect, end up destroying their kidneys. So be careful. Some antibiotics are a problem, and there are some drugs that actually cause wounds. One is hydroxyurea. But on the other hand, there are some drugs that help wound healing. Drugs called hemorrhagiologics, like pentoxifylline. And these are drugs that help the blood work better. And here's my first piece of advice. It'd be hard for you to do today, but as of tomorrow, I want you all to start taking a hemorrhagiologic to improve your blood. And the hemorrhagic I want you to use is called theobromine. And the form of theobromine I want you to use is called chocolate. So I would like you all to have a couple of little pieces, particularly of dark chocolate. And if you don't believe me, do a search, not on Google Scholar or PubMed or one of those, and you'll find many randomized controlled trials of the use of dark chocolate to improve blood. So that's really, really fascinating. Young skin, old skin. You can see it immediately. And this very dry, cracked, fissured skin is very typical. Now, I hope you all use a moisturiser. But unfortunately, the most common moisturiser used out there is sorbolene, which isn't a moisturiser. Interesting. For a moisturiser to work, it needs to leave a barrier on the surface of the skin, preventing the loss of moisture through the skin. But sorbolene, or aqueous cream, which is its other name, has been shown to cause increased water loss through the skin. And in fact, there are some studies that have shown it affects cells in the skin as well, the corneocytes in particular. So don't use sorbolene. It doesn't, in fact, moisturize, it dries the skin. Now, there are some excellent products out there on the market. The QV range I like very much because it's a range. For young people, QV cream is fine. For older people with good quality skin, they can use the ointment. For older people with very dry skin, we use the intensive cream. That's the only cream that doesn't contain a preservative. And for very, very fragile skin, we use the lotion because it spreads easily. Epiderm is very good, and Nivea makes some nice products as well. And this is a beautiful study done by Dr. Carolyn Carville in West Australia. She was looking at the level of skin tears in nursing homes. And so she did a study in 14 facilities, 980 beds, and divide them into two groups, one getting the classic sorbolene rubbish and the other getting the lotion twice a day. And what she found in her study was that those getting the lotion twice a day reduced the incidence of skin tears by 50%. That's statistically significant. So very, very important that you use good quality moisturizers and ones that you can easily use. So what's the right thing to use? Young people, adults, a cream is fine. Older people with good skin, ointment, and older people with fragile skin, a lotion. And that's the best way to go. But be aware, some of these things are actually cytotoxic. And again, this is a beautiful study done in Queensland. See, aqueous cream, paraffin cream, silverzine. And I hope no one's still using silver sulfidizing cream because that's grossly cytotoxic. So be aware that these things we have to take into consideration. And heels get very dry. A lot of people like to use urea. I must admit, I'm not a user of urea because at 10% and above, it can actually have an irritant effect on the skin. So we use lactic acid, and the lactic acids heel balms work very, very well. Skin pH. The skin must have an acid mantle between 4.5 and 5.5. Unfortunately, too many of us still use soap. And if you change the acidity of the skin changes. The permeability goes down. You'll see contact dermatitis, atopic dermatitis. You'll see fungal overgrowth. You'll see staph overgrowth because acid prevents these bugs from growing. And this is the fact. Look at the pH of common soaps. Johnson's Baby, 11.9. Palmolive, 11. Velvet, 11. Cussons, 10.9. Pears, 10.8. Simple soap. Dove, not too bad. Lux, I will remember very early in my career, the common recommendation for nurses was to wash the wounds with Lux flakes. Look at the pH. These are as alkaline as the material you put in your dishwasher. Do you want to put that on your skin? Definitely not. So, Dove is acceptable. I like the liquid ones because the liquid ones are pH'd in this acid range at the skin. The Dermavine, the QV, the Cetaphils, these are all very, very good. Infection. I want you to note down International Wound Infection Institute and to, in fact, go to their website It'll ask you to join, which is free, and then you can download this wonderful evidence-based consensus on wound infection. This is a new document which we only published this year on wound cleansing. So you can download either of those documents from this particular one. So let's have a look at some of the things in it. It talks about the factors associated with the increased risk of wound infection. Again, the diabetic, people with peripheral neuropathy, if they're having radiotherapy, there are a number of things. If they're using corticosteroids, if they're malnourished, if they're obese, alcohol, smoking, illicit drugs, all of these can affect. With acute wounds, it's dirty or contaminated wounds or traumatic injuries. Chronic wounds, it could be the size of the wound, the duration, and all of these are important to think about. And the environmental factors. An unhygienic environment can impact on wound infection. Being in hospital, sad to say that infections go up if you're in hospital. Inadequate hand hygiene. Again, in my pocket, I carry what? My aqueum. I wouldn't go anywhere without it. Hand hygiene, very important. Again, moisture management. All of these things play a part. When we talk about the 5 conceptual stages of infection, is contamination. Contamination is where you've got bacteria that are just not doing anything at all. Colonization are replicating but not doing anything. Local infection, spreading infection, systemic infection. And let's look at those in a bit more detail. The document is wonderful. It goes through all of these various stages, gives you some idea of what you can expect to find, and then it also tells you what to do about it. And I think that's very, very important, that it gives you some advice on where to use what when dealing with infection. So, diagnosis. Obviously, from a medical point of view, we would do a blood test, look for increased white blood cells, looking for CRP, ESR, blood cultures. But for you, you would look at visual things. Again, if you're just looking at basic things, you look for bleeding, maybe friable granulation, again, delayed healing. And one thing that I do, which is may seem crazy, I pH test my wounds. And if you've got a pH of 8, 9 or above, it's likely to be infected. So you look for erythema, some local warmth, maybe some swelling, a bit of muck coming out of the wound. Just the wound breakdown is a risk. Increasing or new pain, and obviously odor is a factor. If it's spreading, you then get cellulitis. You will see this redness moving away from the wound itself, this extended induration. You'll see the lymph nodes starting to swell. You might hear some gas within the wound, and that's not uncommon. Again, when you get into systemic infection, this really can be quite serious because it can lead to some very dangerous side effects, from appetite, fever, pyrexia, sepsis, and even down to death from infection. So, always clean and debride your wounds. And the latest information that we talked about at a conference only a few weeks ago overseas is when you clean and debride a wound, re-cleanse it afterwards to remove anything on the surface. Again, we don't swab wounds generally. The problem with swabbing of a wound is you only collect what's on the surface of the wound. That doesn't mean the wound's infected. If we think a wound's infected, we will biopsy. Now, that's obviously something that nurses can't do. So you need to get your doctors to do that. But we send the tissue to the microbiologist and say what's growing in the tissue. Then we know it's infected. Then we will treat appropriately. And again, there's some beautiful charts within this document that looks at the whole body and the whole issue, which I think is very, very important. And again, lovely diagrams. Again, preventing and reducing microbial burden, optimizing response, again, promoting optimal environment, and again, empowering the person. I always look on the patient as part of my team. We talk to them, we explain to them, we give them printed material of what we want them to do. Because if you do that, then they'll follow your advice. and you'll get better results as a result. So what should you use? Well, tap water. Is tap water safe? Yes, it is. Tap water from quality systems that is all chlorinated anyway is fine. I would tend to use that on clean wounds. If it's infected wound, I wouldn't be using that there. Also, don't put cold water on, warm it to body temperature. A lot of people use normal saline. Yes, you can use saline, but really is an expensive way to clean a wound. Again, surfactants. Surfactants are like a soap without being a soap. They help to lift the rubbish and the loose material off a wound, so they're very, very good. Povidone iodine, betadine, wonderful product. But if you're putting betadine onto an acute wound, put it on, leave it on for 2 minutes, and then wash it off. It's done its job in 90 seconds to kill the bugs. But if you leave it on at 10%, it's too strong and can actually damage. And there's some wonderful, wonderful agents out there. Now, debridement. Obviously, to do surgical debridement, it's got to be done by a doctor. But a nurse can be trained to do simple, conservative, sharp debridement using a curette, using the monofilament type devices. That can be done. Autolytic debridement very much is within your scope. Products like connexin iodine, honey, hydrogels will autolytically help to debride. And we can also use some enzymes. Mechanical debridement, just wet to dry. We don't use wet to dry anymore. That's take your piece of gauze, getting it wet, letting it dry, and ripping the thing off. You do more damage than good by using the wet to dry. But monofilaments are very good for that. Enzymes. There are enzymes you can use, like collagenase, that will help to remove that material. There are some chemicals, but you've got to be careful. And of course, unfortunately, I can't use them in Australia. I did them when I worked in Wales in particular. Maggots. Maggots are wonderful. They will debride a wound within 2 days, but they also kill every bit of bacteria in the wound as well. But we don't allow them in Australia, unfortunately. Pity about that. But there's some other great products you can use. You've got alginate gels. You've got things like DACC, which I'll talk about in some detail later. You've got iodides, like povidone or connexin iodine, and these are very, very useful products to use. I tend to use a lot more iodine than I do silver, because in many cases, iodine helps to stimulate the healing. I like acid because the skin should be acid and the wound should be acid. So we use acetic acid, we use a boro solution, we use hypochlorous acid. This is a modern antiseptic. And the beauty of the hypochlorous acid is it has a beautiful pH, it has a great therapeutic index, and it's not toxic. If you compare that to the old-fashioned one, which was Milton or Usol, these were toxic. We also use citric acid. If you've got Pseudomonas, we use an acid as a wash and leave it on for 50 minutes and then wash it off. And acid will kill Pseudomonas. Does a great job. You've got things like a Tetadine, nice product, and you've got combination ones as well. So there's some good products there on the market. Now, when I say gentle soap, I don't mean the soaps I talked about before. These are the liquid ones. And products like betaine, which is a surfactant, and PHMB. This is a lovely product called Prontosan, which has a very safe therapeutic index, has little or no toxicity, but does a beautiful job. Now, many are still using chlorhexidine. I must admit, in the guidelines, we no longer recommend chlorhexidine. Why? It is certainly cytotoxic. A lot of people tend to be hypersensitive to it, and it no longer has the activity that it used to. So it's one we don't recommend anymore. So I can't overemphasize antimicrobial stewardship. We are responsible for trying to minimize resistance in antibiotics. And we can only do that by not overusing antibiotics in chronic wounds that don't need them, or using antiseptics when they're not necessary. If the wound is clean, you don't need a chemical antiseptic. You just need water or saline. Works well. Okay, let's look at more specific wounds. Pressure injuries. We used to call them pressure wounds or decubitus ulcers or bed sores. We don't anymore. but most of them are preventable. You've got bony prominences all over your body. It doesn't matter where you're sitting, standing, lying, whatever. If you put pressure between a bone and the blood supply, you occlude the blood supply, it becomes ischemic, and a wound starts from below up. You get it from friction, you get it from shear. But be careful. Sometimes what we think is pressure isn't pressure at all. This is continence-induced dermatitis. This is caused by urine and feces. This needs skin management, not pressure management, different completely. What are the greatest risks of pressure? Well, the ischium and the sacrum and the heels. In this study, clearly showed the largest range of there. So you've got almost 30% there, and you've got almost 30% there. So the two biggest areas are the hips and the heels. And the extent of damage will depend on the intensity of the pressure and how long the area remains under pressure. And that's a typical picture. Someone in hospital having probably hips or knees done, nobody looks at the heels, and you can see the purpling. This is the beginning of pressure on the heels. And these will break down, and they'll be pretty nasty. Again, tissue hypoxia, ischemia, you've got a problem. Here is a patient of ours who is a paraplegic, because the Austin is the biggest hospital for spinal injury. He never got a skin break. He developed pneumonia and was admitted to a large hospital for his pneumonia. When he came out, he had this massive trochanter pressure injuries. Why? Because no one recognised the fact he was a paraplegic. A paraplegic is the greatest group to risk pressure. Why? They can't feel and they can't move. Shouldn't happen, but it does. So the classification. Stage 1 is where you've just got redness. If you press the red, it doesn't turn white. This isn't blood supply, it's blood. So therefore, it doesn't change colour. Stage 2 is you've gone through the epidermis into the dermis. Stage 3 is where you've gone through to fascia. And stage 4 is where you've gone to joint capsule and bone. Pretty nasty. Now, the Americans introduced two new stages. One's called unstageable. How a stage can be unstageable, I don't understand, but that's what they do. And suspected deep tissue injury, I must admit, they're not ones that I ever use. The most important thing in management principles is to identify patients at risk. You use a Norton, a Wardlow, a Braden. These are simple little tests. And if we look at Norton, physical, mental, activity, mobility, continence, give them a score from 1 to 4. If you get 16 or below, the person is at risk. If they're at risk, do something about it. Put them onto a pressure relieving surface. Look at their nutrition. All these play a very vital role. And the sort of surfaces they're on. Now, many of you are using these air mattresses, but I've been into many, many facilities where they're not being used correctly. The amount of pressure, sometimes they're on full and they don't go up and down. They're just on all the time. That, in fact, will make things worse, not better. So the surface use is very important. So the alternating pressure are very, very good. And there's some very good foam products as well. And again, risk factors, even sitting, 75% risk in the sacral area as well. Very important. And again, about 20% in the heels. And if they're being placed on a chair to sit, don't just put them on a normal chair with a normal cushion. You need to use a pressure offloading cushion like a Roho. Again, very important to reduce the pressure, and then you won't get a problem. About 16% of Australians at present are over 65. By 2040, 25% will be there, and all at risk of developing skin tears. Any one day, there are 460,000 in high care aged care accommodation, and 59% of people over 65 are in residential care, and 25% in high care. The main cause of skin tears is trauma. whether just from manual handling, from removing adhesive tapes, from falls, from cot sides and wheelchair foot plates, all can cause the problem. Now we classify them, and this is the Australian system called a star system. So it gives a category depending on the amount of damage. That's typical. That's what we call purpuric skin. That's not a bruise, that's just leaky blood vessels. And that's a simple skin tear. That's a staff member's thumb on the patient's arm. That's how easy it is to form a skin tear. Treat it correctly, that'll heal quickly. Treat it incorrectly, it becomes a chronic wound. And that's a particularly bad one. Like purpuric skin loss of tissue. It takes a lot to get me angry. But I got angry a couple of years ago when someone came in with a skin tear like this that had been sutured. Now, you cannot suture a spider web. Epidermis is less than a millimetre thick. You cannot suture it. So, I did a very big study some years ago in nursing homes in Victoria. We looked at 3,000 beds, and we found that 50% of all the wounds were skin tears. So, we developed a protocol for treating. So you just stop the bleeding. Many of these older patients are on anticoagulants. They will bleed. You might need to use a calcium alginate, like a Calcistat or similar, to stop the bleeding. Cleanse it with just tap water, gently, pat it dry. If you can, get the flap back into place. Now, I know many nurses will say, oh, you can't do this. I still use steri strips to hold my flaps in place. I know the international body doesn't recommend steri strips, but something I've always done. And I still do it, but you apply them with no tension. Then, if it's very dry skin, I put a bit of gel on the peri-skin, and my primary dressing is a silicone foam, a Mepilex, an Alleven Life. And the other crazy, and what I do on the outside of the dressing, I put an arrow to tell me when I take it off, I don't take it back across the skin tear, away from the skin tear. And the other crazy thing I do, I put a couple of layers of tubey grip. Why? That little downward pressure helps the skin to attach, and that all works fine. What I also then do after the first 3 or 4 days, I add a little patch of zinc paste bandage. Why zinc? Because zinc stimulates epithelium. Now let me give you an example. This is an 88-year-old lady, Dutch lady, loved her garden, was in the garden, walked into a concrete block, got a massive skin tear. Because she has AF, on warfarin, she bled. Her daughters rushed her to a private hospital EAC. And they said, oh, we'll have to get a plastic surgery. You're going to need a skin graft. They said, no, a skin graft, an 88-year-old, come off it. So they put on Gelanet, gauze, and a crepe bandage. I saw her the next day, and I thought, dreadful. Cleaned it all up, got the flat in place, a few steries, my Mepilex over that, and my tubey as well. This is day 1. You can see a massive skin tear, a lot of hematoma there as well. You can see I put 5 steries just to hold that flap in place. This is day 1. This is day 16. Where is the skin tear? It's gone. Normal skin. You can see the white from the zinc. But is it rocket science? It's understanding how to make these things heal and heal quite quickly. But remember, in your older patients, you need to look for risk factors. The aging, paper-thin skin, if they're frail, if they've got dementia, if they're malnourished, all of these issues. And if you find any of these particular issues with them, do something about it. Don't just look at them and think about it. Get them getting good moisturising. Look at padding. Look at ways of minimising the risk of skin tears. And it plays a very important part. Now, looking at dressings, you should always allow a couple of centimetres of dressing bigger than the wound, with the exception of things like the alginates that go into a wound. But mostly, if they go around a wound, put 1/3 above and 2/3 below. Why? Gravity. Where will exudate flow? Downhill, never flows uphill. If you go 1/3, 2/3, you increase the wear time of the product. You get better value. Don't take them off too quickly. Be very careful with older people. All very important. So, let's have a look at our groups. And again, I put Gelnet there just because I hate it so much. It's open weave, tissue will grow through it. It is gauze which shed fibres and is absolutely saturated with paraffin. Why do we put paraffin on a baby's bum? Vaseline, to prevent nappy rash from urine. If you put paraffin on a wound, you prevent the flow of exudate through the wound. Not a good idea. So don't use Gelnet anymore. You can use Tudicerin, made by the same company. A beautiful product. Tightly meshed, not gauze, no paraffin. Or you can use Adaptic. Beautiful product again. So, and the crazy part is, the modern ones are no more expensive than the Gelnet. So that's a fallacy. So these things are useful. Now, if you're putting a tool on someone with very fragile skin, you can't use any of those. What we use is a silicone tool like Mepitil, because that can safely stay on. And the beauty of that is, yes, it's a lot more expensive, but that can stay in place for up to 2 weeks, whereas these ones you ought to change every few days. So they're contact layers, very superficial wounds. They'll need a secondary dressing. They have no absorbency capacity. They just need to protect. That's all they will do. Melanin Cutulin, again, very popular. But the problem with melanin and Cutulin, they have minimal absorption. There is no point using melanin and Cutulin on an exudating wound, because if you'll be lucky if they last for 4 to 6 hours, which means you've got to change them 4 times a day. Sure, they're $1 a piece, but if you're doing 4 a day, that's $4 a day times 7 is $28 for the week. Why not use Mesorb, which costs 60 cents more than a melanin, $1.60, which absorbs 50 times more exudate than the melanin? It's a no-brainer, but people keep using melanin. Mesorb, Vliwazorb, Zechuvit. There's some wonderful, vastly more absorbent, basic, simple dressings that are not much more expensive than your Gelinets, than your melanins and Cutulin, but are so much more cost-effective. And you have to look at those issues. So, if it's likely or no exudate, use your melanin Cutulin or your Primapore. Remember, Primapore is not waterproof. But if they're oozing, you have to use the Mesorbs, the Vliwazorbs, or the Zechuvits. Film. Film is great, but you've got to be very careful in using a film on an older person. Why? Because it sticks aggressively. And if you pull it off, you'll actually pull skin off. But there are today versions of film safe to use on older skin. They make a silicone film. The Moonlicker people make one. The Essity people make one. Smith & Nephew make one. So they all now make a film that is safe to use on older skin, but you can't use the regular ones. But for other than older people, the Opsites, the Opsite post-ops, the Tegaderm pad, all work well. And of course, you can get them in the rolls. The Opsite FlexiGrid in a roll, the Fixamol Transparent in a roll. And they're very, very good. The other thing is, don't use Band-Aids, please. You take a Band-Aid off after 1 day. What does the whole area look like? White and shriveled. It's macerated. Band-Aids don't breathe and they're not waterproof. Use the NextCare waterproof dressing. The same size as a Band-Aid, the same mechanism of Band-Aid, but it's film. It breathes like skin. It won't macerate. It's waterproof and will last for days. So, film plays a huge role. We can use it for lots of things. For the small non-bleeding scratch, for non-bleeding cut, over sutures, but don't use them on fragile skin other than the new versions that are usable for fragile skin. Very old dressing are the hydrocolloids. Good dressing, but we don't use them as much today. One of the problems with the old duoderms and Comfeel is that they're occlusive. If you occlude a wound, you'll get anaerobes growing underneath them. So when you take them off, you've got this yellow pussy-like material, and you think, oh, it's pus. No, it's not pus at all. Just breakdown problems, and they'll smell because of the anaerobes. Don't use hydrocolloids on diabetics. They're really contraindicated. But for other wounds, you can certainly use them. To me, the dressing that is safe to use on any wound is foam. Foam is the go-to dressing because you can use foam on any wound, from Alleven to Permafoam for the standard type patients. For the fragile ones, the Mepalexes, the Alleven Lights, the Alleven Gentles, they're wonderful. Foam is absorbent, foam is thermally insulating, foam is cushioning. So if you want to know the go-to dressing, go to foam. You cannot go wrong with foam as a major dressing. You really can't. Gels. Be aware that gels come in 3 types. You've got your sterile gels like your Intrasite and your Purulin, are the ones you put on a wound to deslough a wound. You've got your solid gels and your Solicites, which are preserved gels, which are for burns or little minor scrapes, fine. Or you've got your antiseptic gels like your Flaminel gel or your Protosan gel, because they contain antibacterials. So hydrogels are great to rehydrate dry tissue, to soothe, great for chickenpox and shingles. That's something I postulated many, many years ago. Don't use calamine lotion. Use one of the amorphous gels like a solid gel or a Solicite on chickenpox and shingles, and you won't get scars and you'll minimise the postherpetic neuralgia. Again, gels are very good. You can also get sheet hydrogels, which are great for burns. Alginates. Now, alginates have 2 roles. One is as a hemostat. Your Caltastat, your Algicide M are great for stopping blood. You can also use them as a packing material in a cavity wound, and they work quite well for that. So, good product as well. Iodine. I don't use betadine much at all, other than pre-skin procedure. But Iodosorb is a wonderful product. Connexima iodine, 0.1% iodine, so it's not strong at all, so it's not toxic. It will kickstart a wound. It is the primary choice for your standard diabetic wounds. You can put the paste on, put some foam over the top of that, change every 3 days, and be amazed how that works. The other is inidine. Again, inidine is again a complex. It's a polyethylene glycol one, which is again, instead of being 10%, it's 1%. So again, as a dressing, works extremely well. Silver. Yes, silver has a role, particularly in Pseudomonas and in burns. You've got, it's a very expensive dressing, unfortunately, but the facts are that sometimes you need silver because there are certain bugs that silver kills best. So silver is a very good one to use for specific types of wounds. This is one that's probably not well known, and it's called Sorbact. Sorbact is a fascinating product. It's DACC, which is a fatty acid, and it will bind bacteria or fungi to its surface and inactivate them. It is totally non-toxic, contains no chemicals. It's just a fatty acid, but it does a stunning job. You use it on infected wounds, on colonized wounds. You can use it on fungi. You see, that's a fungus under the breasts. I use the gel version, and within days, the pain is gone. It's all settled down. You can use the ribbon one on the toes for tinea. Works very well. Bandages. I use the French pronunciation when I talk about crap bandages, because really they are crap. If you want to hold a dressing in place, I don't use crap bandages. I use a cohesive bandage like Hadigor's cohesive, or I use Tubi Fast. Maybe it's separate to make Tubi Grip, but it's not elastic, it's not compressive, and they make them in every size for legs, arms, head, body. They're very, very good as a retention, not crap. Tubi Grip, we all know Tubi Grip. In sports medicine, we use it for hips and for ankles and wrists and elbows and wherever. But you can also use Tubi Grip for compression. Older people say, it's too tight. So you can use 3 layers. It's a beautiful study done by Professor Carolina Weller. First layer from toe to knee, 8 millimeters. Second layer from toe to the widest part of the calf, 16 millimeters. Third layer from toe to about 5 centimeters above the ankle bone, 24. So you've got 24 millimeters at the ankle, 6 at the knee, at the calf, 8 at the knee. Graduated compression. Because it goes on 8 on top of 8 on top, it doesn't feel tight. So older people will wear 3 layers of Tubi. It's better to give them some compression than none, and that's important. Coban, Co Plus, these are elasticated bandages that are also cohesive, but they will provide about 25 millimeters. We use them as part of a multiple layer compression system. Now, before you ever apply compression, make sure there isn't an arterial component. So, is the foot warm? Good. Cold? Bad. Pink? Good. White? Bad. When you squeeze the toes, does it refill quickly? Good. Slowly? Bad. Can you feel a pulse in the foot? Good. No pulse? Bad. Do not apply compression if any of the ones are in the negative side until you have a proper study, whether ankle brachial index or a duplex study, because you'll do more damage than good. You play an important role in addressing and managing wounds, so your choice of treatment must depend on the wound type and what you want the product to do. You don't just go to the shelf and pick something off the shelf. You say, what do I want the product to do? I want it to be absorbent. I want it to be antibacterial. You choose the product that suits. It's essential for you to understand when to involve a wound specialist. Again, don't just keep going on for months and months and months. If you're not winning, get some help. And it's not rocket science. It's often a clear misunderstanding of identifying and treating both the cause of the wound and the wound itself. So, keep up to date with your reading. Again, at times it might seem difficult. And remember, wound management is a multidisciplinary event. When you work in a team, communicate. Thank you.
Well, thank you very much, Dr. Sussman. So now is your opportunity to ask any questions today. So could you please put your questions in the chat box and I'll ask them on your behalf. Dr. Sussman, you've given us such practical advice today, everything from good skincare, hydration, vitamin D, and I'll be taking a few things away personally, and even, to the details of choosing the right dressings for skin tears, etc. So it's been really good. But building on that, if we're doing all these things and managing a skin tear appropriately, when should we be thinking about escalating to the GP or even to hospital care? When's the right time?
The only time you'd escalate is if the skin tear goes wrong. In other words, it becomes infected or you lose that top layer of skin completely, then you're looking at more complicated management techniques. But generally, there is no reason that any of you cannot manage a skin tear given the protocol I've shown you. Because it works. I showed you on that ADL lady. Use the standard protocol and it works. So it's within all of your bailiwicks, your scope of practice to treat skin tears. Absolutely. And the other thing is then moisturize, moisturize, moisturize to prevent them coming back again and looking for factors. What we also tend to do is we use Tubifast. That's that beautiful tubular material we use for retention as a sleeve to protect the skin. That's another little trick we use.
Yep. Great. Thank you for that. I don't see any questions in the chat. I'm just giving another moment, but I think that there are no questions. So thank you very much.
Have I stunned you too much?
Maybe. There was a lot of detail there. So
well, yeah, again, my recommendation to do two things. Go to the International Wound Infection Institute and download the wound infection document and the wound cleansing document. Go to the Wounds Australia website and you can download some things there. There are some great websites available that you can use. Wounds International. There are a number of great provisions of good education for you.
Wonderful. We do have one question in the chat now.
Good.
Do you advocate for pain management before dressing changes?
Do I advocate
for pain management before dressing changes?
That's a very good question. The problem with pain management, if I know someone has pain at dressing changes, I usually tell them to take some Panadol just before they leave to come to the clinic. The issue that you have is, yes, you can use a topical local anesthetic, but you have to be a bit careful with them because they are vasoconstrictive. So although they might ease the pain, they can cause damage. But in some cases, if I'm surgically debriding, I'll always use a local on them. The other thing is, if you use the monofilaments for debriding, they're not painful at all. But it is an issue. Some patients don't cope. And again, then think about the choice of product you're using. Because if the product is sticking and it's painful to remove, you're using the wrong product. Use a soft silicone that doesn't actually stick. It appears to stick, but doesn't stick, so you can remove it atraumatically.
We have another question around Steri-strips. Can they be used in the aged care setting? We were advised a long time ago that this type of dressing should not be utilised. Cannot remember the reason. Any thoughts? Thank you, Professor.
Well, the reason that they don't want you to use it is if you use them incorrectly or try to remove them, yes, you can cause major damage. But I still use them because I don't take them off. I let them, in fact, fall off, or I use a citrus oil product, a Convacare adhesive remover, and that dissolves the adhesive, they just fall off. So to me, I like to stabilize my skin tears really well, and I find it just a 2 or 3 steries will just keep it in place, and then the tubey grip over the top. And you saw within 16 days, and it completely rehealed, and you wouldn't know there was ever a skin tear. So yes, I understand why they generally say don't use them, because used incorrectly, yes, they'll cause huge trauma.
Wonderful. Thank you very much. So can I ask, we've got another one, Claudia.
We have a patient who has a wound on her ankle, and she has bad perfusion, and she is wearing compression.
Bandages.
Well, my question is, why is she wearing compression if she has poor perfusion? What is the best indicators of assessing how long dressing should remain to do? Well, I'll answer that question first. I have what's called a 2-week rule. If I'm using a product and you see no improvement in 2 weeks, you need to change. But you should not be using compression on anyone with peripheral arterial disease until such time. She was advised from her vascular surgeon. Well, in that case, I'll still use compression, mild compression, on someone that has some peripheral arterial disease. But it depends on how much compression. I wouldn't use, initially I'd probably start with 1 layer of tubing, 8 millimeters. If that all goes well, I will add the second layer, 16 millimeters. If that still goes okay, I'll add the third layer, 24 millimeters. But keep it at no more than that level, because you risk occluding even further. But if the vascular surgeon has said it's perfectly safe to use some compression, obviously they're sufficiently satisfied that the occlusion of the arteries is not gross, therefore there's still some safety in applying compression, particularly in patients with mixed disease. If they've got both venous disease and arterial disease, then they do need a bit of compression, but you've got to apply a safe level, and that's the important thing.
Okay, so that was a thank you there from that for Claudia. And another question, how long to assess wound and products would be best before getting a wound consultation?
Well, again, my general rule is if you think you've got the diagnosis right, and therefore the treatment should be logical, if you see no improvement after 4 to 6 weeks, then something isn't the way it is. Therefore, get some help.
Yeah. And Professor, apologies, this person joined in the middle. We use betadine most of the time. Could you please tell us what we need to keep in mind with betadine? If it was explained, please skip. Thank you.
Okay.
So it was very
if you're using betadine on the skin before you do a procedure, it's perfectly safe to use 10%. If you're putting on an ischemic diabetic wound to keep it dry at 10%, it is perfectly safe. But if you're putting on an acute wound to decontaminate an acute wound, that's the one you need to leave it on for no more than 2 minutes and wash it off, because 10% is cytotoxic. It damages healthy cells. It kills bacteria, but damages healthy cells. So it's a matter of where you're using the betadine. Betadine is a wonderful product. I mean, iodine is the best antiseptic. It's bactericidal, fungicidal, sporicidal, virucidal. So its spectrum is brilliant, but it's the way you use it that's important.
Thank you, Professor. So can everyone please take the time to complete the participant evaluation survey via the QR code on the screen or link in the chat, I think, coming. Thank you very much to our presenter today. We're very fortunate to have had such expertise available. Thank you very much.